Hello, healthcare professionals. Welcome back to Decoding Respiratory Medicine, your go to source for medical education and exam preparation. I am Sidra Fayaz, and I am thrilled to have you here today for another session of high yield learning. Today's video is gonna be an absolute must watch, especially if you're gearing up for your exams or looking to deepen your clinical knowledge. We are going to dive deep into a series of best clinical questions that will not only test your understanding but also going to sharp those diagnostic skills that are crucial in the world of medicine. As always, make sure to engage with the questions, pause the video if needed, and think through the scenarios. Learning is an active process, and the more you invest in these questions, the more you will learn. So before we jump into the challenge, if you haven't already, consider subscribing to my channel and hit the notification bell so you never miss out on the latest medical content. And also, if you find this video helpful, don't forget to give it a thumbs up because it truly makes a difference. Let's begin. So, best choice question practice, and here is the first question. 62 years old man presents with a 4-month history of breathlessness on exertion. He has no constitutional symptoms and no past medical history apart from hypertension. A chest radiograph reveals a large left-sided pleural effusion. Which of the following is not a diagnostic recognized cause of pleural effusion? So, the highlight is not. Options are asbestos exposure, bronchiectasis, mitral stenosis, pancreatitis, or peritoneal dialysis. Again, which is not a recognized cause? You can pause the video and you can type your answer in the comment section as well. So let's exclude it out. We know that asbestos exposure causes a pleural effusion, so that's rule out. We know peritoneal dialysis also causes, and pancreatitis also causes pleural effusion. So the things which left is bronchiectasis and mitral stenosis. If the mitral stenosis is causing heart failure, it can also lead to the left-sided or the pleural effusion. So the answer is bronchiectasis. Let's go to the next question. A 61 years old man with a prior occupational asbestosis contact has known asbestos related pleural plaques. Which of the following are not compensatable either through civil or government schemes? Options are benign asbestos related pleural effusion, diffuse pleural thickening, lung cancer with asbestosis, lung cancer without asbestosis, or malignant mesothelioma. So the answer is yes, benign asbestos related pleural effusion. Let's go to the next question. 23 years old woman is admitted to A&E with sudden onset chest pain and breathlessness. She is found to have a large left-sided primary spontaneous pneumothorax, which is successfully treated with needle aspiration. She tells you that she is getting married next week and she has to fly. How long after the radiological resolution of primary spontaneous pneumothorax should a patient be advised to refrain from air travel? Options are 1 to 2 weeks, 6 weeks, 6 months, 1 year, or permanently. Answer is 1 to 2 weeks. Next question. A 68 years old patient referred to the rapid access clinic with a 3-month history of cough and a 1-month history of increasing weight loss and lethargy. He is a current smoker of a 20 cigarettes per day. His initial chest x-ray showed a central mass and his CT scan confirms a central mass with ipsilateral mediastinal nodes and no evidence of distal spread. He is staged at T4N2M0. A bronchoscopy is undertaken and the histology report is as follows. Multiple small pigmented cells with scanty of cytoplasm and distinct nucleoli in keeping with small cell lung cancer. Given the diagnosis, what is the most appropriate next step in his management? So this question also revised us about the histological appearance of small cell lung cancer, which is multiple small pigmented cells with scanty of cytoplasm and indistinct nucleoli in keeping. Small cell lung cancer. So what would be the treatment in this question? You should know what are the treatment options for a small cell lung cancer according to this stage, as N2 involvement is being there. So surgery is not the option, and in the provided options or the chemotherapy names are being there, and we have to select one. Is it a carboplatin, cisplatin or etoposide, cisplatin and pemetrexate, erlotinib or vinorelbine? So answer is cisplatin and etoposide. The most appropriate next step in the management of this patient with a small cell lung cancer, specifically at T4N2M0 stage, would be to initiate a chemotherapy with a combination of cisplatin and etoposide. Moving to the next question. 80 years old man is referred to the respiratory outpatient clinic with breathlessness, cough and weight loss. So breathlessness, cough and weight loss in his 80 years of old. He is found to have a medium-sized right-sided pleural effusion on chest x-ray. He lived the first 30 years of his life in Pakistan and remembers being treated for tuberculosis at the age of 18. Which of the following statements regarding TB pleural effusion is most true? Whether a tuberculous effusion is mediated through a type 3 hypersensitivity reaction, combining pleural biopsy culture and histology for caseating granulomas has a diagnostic sensitivity of almost 100%. Pleural fluid analysis for ADA, adenosine deaminase, is a useful diagnostic confirmatory tool in areas with low incidence of TB. Pleural fluid culture microscopy for AFB smear has a diagnostic sensitivity of 50%. The diagnostic yield for TB from thoracoscopic pleural biopsies and Abraham's pleural biopsies is equally high. Answer is combining pleural biopsy culture with histology for caseating granulomas has a diagnostic sensitivity of almost 100%. Next question. 83 years old man is seen on the acute medical intake with increasing shortness of breath. He also complained of 1 stone weight loss and increasing lethargy. He is an ex-smoker with a 60 pack per year history. On examination, he is clubbed and cachectic. There is a hard node felt in the right supraclavicular region. Examination of his precordium reveals a distended veins and he noted to be quite flushed. A CT scan demonstrates a large mass measuring 9 cm in the right upper lobe extending into the mediastinum. There is an extensive mediastinal lymphadenopathy and a large right supraclavicular node. There is also 3 cm nodule in the left upper lobe. What is the TNM staging? So the TNM staging for the described case would be T4, the primary tumor, the large mass in the right upper lobe is extended into the mediastinum. N3, because there is an extensive lymphadenopathy in the mediastinum. And M1A, presence of a distinct metastasis in the large right supraclavicular node. If you would like a lecture on TNM staging, please comment below in the comment section, and I'll try to make one video on TNM classification. So the answer over here is T4 N3MA. Next question. 23 years old man is found to have a large right-sided pleural effusion on CT scan. He subsequently undergo a needle aspiration of the effusion under ultrasound guidance. Effusion is milky in appearance, a cholesterol level of 402 mg per dl and a triacylglyceride level of 42 mg per dl. What is the most likely diagnosis? Hodgkin's lymphoma, milk alkali syndrome, esophageal rupture, pleural malignancy, pseudocylothorax. Answer is pseudocylothorax. Pseudocylothorax is a condition where a pleural effusion has a milky appearance similar to chylothorax, but it is not a true chyle. It's lymphatic fluid. The key distinguishing feature is a biochemical analysis of the pleural fluid. The pseudocylothorax cholesterol levels are significantly elevated as seen in the provided value, that is cholesterol of 402, and the triacylglycerides are relatively low, which is opposite to the chylothorax, in which triacylglyceride levels are significantly elevated. Next question. A 78 years old patient is being investigated for a chronic cough. He is an ex-smoker with a 55-pack year history. He has a cough producing large amount of discolored sputum, and an HRCT was performed to assess for possible bronchiectasis. It showed cylindrical bronchiectasis in the right lower lobe and a solid 9.5 mm left upper lobe nodule. Due to its size, his risk according to the Brook model was calculated and reported 10%. What is the most likely appropriate next step in the management? So now the answer will be depend on, that's the Brook model, risk was 10%. Is it a CT guided biopsy, CT surveillance scan at 3 months, CT surveillance scan at 6 months, CT surveillance scan at 12 months, or PET scan with risk assessment using Herder model? Answer is, the most appropriate next step in the management is CT surveillance scan at 3 months. Next question. 67 years old woman is referred to the rapid access clinic with a 6-month history of a dry cough. She presented to GP 3 weeks ago with these symptoms, but also complaining of weight loss and lethargy. She denies fever. There is no history of TB. She is a current smoker of 20 cigarettes per day, having started smoking in early teens. Clinical examination is essentially normal, although she is noted to be a little cachectic. Chest X-ray reveals a large cavitating mass in the left upper lobe. Blood test sodium 143, corrected calcium 2.97, potassium is 3.7, CRP 25, urea 6.2, creatinine 89. What is the most likely diagnosis? quite easy one. Adenocarcinoma, lung abscess, small cell lung cancer, squamous cell lung cancer, or TB. So this question is revising us about that the most likely diagnosis in this case, giving the clinical presentation and findings, is a squamous cell lung cancer. Presence of a large cavitating mass in the left upper lobe of the lung, along with the patient's history of chronic symptoms of chronic smoking and symptoms like cough, weight loss, and lethargy, is a characteristic of squamous cell lung cancer, and the cavitating nature of the mass is a common feature of the squamous cell lung cancer. So that's it for today. I will be right back for another video. Thank you.